Moving on to the other important variant of chronic conjunctivitis, which is follicular in variety. This is a picture of follicles. You have follicles in the lower fornix and in the upper lid. So one of the most common causes of follicular conjunctivitis is benign folliculosis, which we see in children, which usually occurs in a quiet eye that does not require any treatment. Inclusion conjunctivitis caused by Chlamydia trachomatis is usually associated with inflammation and is one of the most important causes that you need to rule out when you see an adult with a follicular conjunctivitis with a red eye, where you need to go ahead and do a conjunctival scraping to look for any inclusion bodies, and also you can isolate the chlamydia in culture or by PCR. Very, very rarely, especially when you have a unilateral follicular conjunctivitis, it might be an indicator of a lymphoma, but that's a very, very rare situation, but something that should be kept in mind. The treatment for adult inclusion conjunctivitis is basically systemic, and azithromycin 1 gram single dose is what is recommended in the form of treatment for these eyes. Molluscum. This is another important cause for follicular conjunctivitis. This patient has multiple lesions, but sometimes you might just have one or two along the lid margin, which are constantly liberating the organisms into the ocular surface, which leads to surface inflammation, and you have to identify and treat the Molluscum Contagiosum with cryotherapy, and that's how you will resolve the inflammation in the eye. So when we are at it, since we have already spoken about Demodex and molluscum, another entity that can lead to chronic conjunctivitis is lice along the lid margins, which also is something which for which you have to epilate or just cut off the lashes, smother the eyelid margins with ointment, and usually it is taken care of. But these are instances where you have to carefully look for these lesions or organisms in the eyelashes. Toxic medicamentosa is another cause for follicular conjunctivitis. This is one eye of the same patient on anti-glaucoma medication. This is the other eye where you can see there's no staining, but this is the eye that shows almost a staining in the inferior 2/3 of the cornea. But I again don't have a very classical picture of toxic medicamentosa, but you have inflammation that's more characteristically along the lower half of the ocular surface. Moving on to membranous variant of chronic conjunctivitis, probably the only one is Ligneous conjunctivitis, and usually these patients present with this kind of thick membrane on the palpebral surface, which is normally surgically removed. You can just excise it, and they have to be treated with topical heparin, topical fresh frozen plasma, topical steroids, and topical cyclosporine. 2% is what we normally use in these kids. In the last 20 years, I've seen 4 patients of Ligneous conjunctivitis, and it's a manifestation of hypoplasminogenemia, and it can sometimes continue to linger on despite the treatment, especially in children, for months to years before it actually starts settling down. Moving on to another important variant of chronic conjunctivitis is the cicatrizing variety, which again is a very important cause that has to be identified and treated, especially because some of them could be potentially sight threatening. And when you're talking about cicatrizing conjunctivitis, you again need to divide it etiologically into the following. It could be post-infective, post-trachoma, could be post-adenoviral conjunctivitis, which is a very common cause of cicatrizing conjunctivitis that is usually not considered when you see these patients. Of course, immune-mediated forms the most important aspect here with SJS, OCP, and rarely graft versus host disease. Trauma, as in chemical injuries, masquerades, and others such as drug-induced pseudopemphigoid or post-surgical. The importance here is to differentiate between each of these based on the nature of onset and the progression of the cicatrization, the history and relevant investigations. So when you see a patient who presents to you with this kind of cicatrization, where you see some amount of fibrosis and bands of symplepharon and subconjunctival cicatrization, you need to have a plan in your head as to how you're going to go about ruling out each of your diagnoses. So if it's Stevens-Johnson syndrome, you're going to have a classical history of drug reaction of the patient having had a vesicular bullous disease involving the skin and the mucosa, and in the acute situation, it would have been a life-threatening disease. When the patients usually present to you in the chronic ocular stage, apart from the cicatrization, they also have classically features of lid margin keratinization. And one of the important pointers towards SJS is the very acute onset and the classical systemic history. Trachoma is another important cause, especially in our country, for patients who come from endemic regions. Even minimal trichiatic lashes such as these should point towards the possibility of the patient having trachoma. You invert the lid, you see the Arlt's line. These are the Herbert's pits, and very classically on meibography, they usually tend to have a complete wipeout of the meibomian glands. So this is a slightly more better picture of the Herbert's pits and the Arlt's line, and it's usually associated with cicatricial changes and corneal pannus. And the treatment is to address these sequelae of the disease. With respect to graft versus host disease, you will have an obvious history of bone marrow transplant, and the most common features usually are dry eye, and phoneal shortening is usually very mild. It's more often the subacute or the chronic GVHD. The acute GVHD is rare, but then the picture is usually similar to SJS or 10. Atopy, we already spoke about it. It's associated with skin disease, and you have to treat it in association with a dermatologist. Post-adenoviral conjunctivitis, especially when you have severe pseudomembranes in the acute stage, it's very important to ask the patient whether he or she has had conjunctivitis in the past, whether other family members also had it at the same time. And most of the times, these patients would probably recall when asked that, the dryness or these issues started after they had an episode of conjunctivitis in their eyes or in the family, amongst multiple family members of the family. And when you have these severe pseudomembranes in the acute stage, they can actually, especially when they are present in the superior-temporal quadrant, they can actually cause a scarring of the lacrimal ductules and therefore lead to dry eye. And in these eyes, in most instances, all that they need is a punctal cautery to address the dry eye if the dry eye is very severe. The most important cicatricial disease that one needs to differentiate from SJS and all the other diseases is ocular cicatricial pemphigoid, wherein it has an insidious onset. You could have recurrent episodes of inflammation. You can have associated oral ulcerations. And the most important feature of OCP is the progression of the disease, as I shall show subsequently. And with drug-induced pseudopemphigoid, it's usually secondary to anti-glaucoma medications that lead to these kind of bands, especially in the inferior fornix. And there's a very nice paper that's been written by Guillermo on drug-induced pseudopemphigoid. So these are the lesions that you need to most commonly think of when you're looking at a cicatricial conjunctival disease. And when you want to decide your plan of management, you have to answer a few questions. Is the eye quiet? Is it inflamed? What is the severity of the inflammation? What are the associations? Is there an associated dry eye? Are there associated adnexal conditions? Is there any exposure? And if so, each of these have to be treated. Of course, you have to know what the visual status of the patient is. And once you have ruled out these mechanical causes of inflammation, you can attribute the residual inflammation to the underlying immune disease if you're dealing with an immune disease. And especially with SJS and OCP, management is very crucial because if left untreated, it can lead to corneal blindness and end-stage ocular surface disorders. So as I said, you have to treat the causes for persistent inflammation. For the dry eye, if it's very severe, punctal cautery has a significant role to play. A small procedure can bring about a big change in the ocular surface. In SJS, for lid margin keratinization, we normally do a mucous membrane grafting for these eyes to reduce the blink-related microtrauma, as is indicated over here. And visual rehabilitation for end-stage disorders obviously includes the use of various types of keratoprosthesis in these patients. And this is the algorithmic approach to management of SJS, which we have published as a comprehensive approach to the ocular sequelae of patients of Stevens-Johnson syndrome.